Good morning and welcome everyone to the Social Simulation Week workshop session on simulation in the times of COVID-19. I'm Harko Verhagen, and together with Alexis Drogoul, I'm chairing the session, and we organized this. We are very happy to see so many participants and presenters. So we will have a tight schedule today. As you have seen the instructions in the chat, we will use Google Doc to formulate questions, which means that we also can answer questions afterwards, and we will even keep the questions alive. So this will be a better way of saving the communication that we have than the Zoom chat. With that being said, I think we can just move on to the next slide, and then I need to make sure that I'm in the right window, of course. Here we go. So we have 4 sessions with short breaks between the sessions. Each session will have a few presenters that will have up to 10 minutes. Some people will have just 5 minutes for their presentation. And if they are slightly shorter, they may get 1 question after the presentation. But in general, the discussion will be at the end of the session, and we have about 10 minutes in each session for these discussions and questions. With that out of the way, we can start with the first session, which is more like a general take on different looks on how we can use social simulation in these COVID times. We have a total of 5 presentations with people from different backgrounds, which is, I think, also quite interesting. And we're going to start with Christopher Watts, who has the presentation Agent-Based Model Looks at an Epidemiologist's Model. Chris, if everything is okay, you are co-host, so you should be able to make the presentation work without further ado.
Okay, can you see it?
I have to stop sharing, and now you are. I was blocking you. There you go. Yes, Christopher.
Okay, all right, off we go. 10 minutes. I'm going to go through this very fast, but the slides will be available on GitHub. I'll post a link in the chat so you can look at them at your leisure. Right, I'm going to start with the February question. It's February 2020, there's a new disease out there, and in 3 weeks you've got to advise the UK government on what they should be doing about it. Which modelling tools are you going to reach for? Well, as we know, the answer was not agent-based modelling. So what was the answer, and what did it offer? Because agent-based modelers might see the world a different way. In March, I started on a model in which heterogeneous adaptive agents were going to perform routine activities in locations, homeschool work, according to personal schedules, which we could base on survey data. And when things change, like schools closing, they would innovate to find new things to do. And this would create a bimodal, bipartite transmission network. And if you heard Joshua Epstein last year at the conference, you'll understand some of the inspiration for where I was coming from here. So I show my model to a team of modelers, and Nigel notices the following, that none of us are epidemiologists. Why should anyone listen to us? And it's a good question. And Nigel's suggestion was that we find some serious epidemiologists with a serious model, and we dock with that, and that way we'll demonstrate our competence. So the model we've identified was from the London School of Hygiene and Tropical Medicine. So I'm going to call it the hygiene model for short, and it's described in the paper Davies et al. Published in the Lancet. And once we've docked with it, then we'll start adding some of the features we associate with an agent-based model like the one I started with. So what can I tell you about it? Well, it's a compartmental model, which is, if you like, a quick and dirty solution. They're very quick to create, drag and drop. They're very quick to run it in a spreadsheet, and they've been around since the SIR model, since 1927. And at their core is something called the force of infection. This is the idea that the rate at which infection events occur for a susceptible person is a linear function of the infectious proportion of the population. But this gives rise to something known as the universal mixing assumption, which is the idea that I can be having social contacts with anyone in my population, even if it's the size of the UK. So ignoring where they are spatially, ignoring social networks. Now, the hygiene model does reflect some of the criticisms of differential equation models like the SIR one. So the hygiene model is stochastic. It divides the population into age groups, and it divides the UK into counties and runs simulations for counties, 186 of them, and then sums up the time series to make the UK. And it's also, oops, apologies for the cat. It's also an individual-based model, which means each individual in the population, as they move between states, their state transition times are going to be sampled from a probability distribution, in this case a gamma distribution, that allows them to control the variance in transition times. But it also means that if they're modeling 66 million UK people, they need hundreds of millions of random numbers every simulation run. Okay, I'm going to skip over that. What did we learn as we tried to replicate this model? Well, the first thing I learned was I'd got to restructure the compartments. I said they were quick and dirty. Well, they've got a transmission model, an SEIR type, but then to estimate the number of hospital beds they're going to need and the number of deaths that are going to occur, they clone people in the transmission model and feed them into parallel models. For an ABM, I want my agents to undergo processes in the correct sequence, so I had to restructure. Another thing I learned that's quite useful for us is that size overall does not matter. If you've got a compartmental model that produces, say, peak cases that are X% of N people, where N is the population size, well, if I simulate a smaller population, it's the same X%. So I could do an agent-based model of 100 agents and then just rescale the numbers. But population size does affect the time to peak cases and the time to hospital beds filling up. So you may need to rescale the seed infections with that. And if you've read our ROFAS model, our ROFAS article, you'll know that there's a problem associated with that. I'm not going to discuss that today. Instead, I'm going to tell you they make a lot of assumptions in their model that they don't give much argument. No, they don't give really any argument for some of these things. There's no empirical justification either, and there's very little sensitivity testing going on. Yeah, they did this in a rush. Perhaps more serious is in replicating their model, I discovered a bug in it. They've overestimated the impact of policy interventions. All their charts are going to have to be redone, a major rewrite of the paper. So to sum up what we found about them, they've added a lot of complications to the SIR model, to the differential equation models. And as a result, there's a lot more code for them to check. Computation takes longer. We're now running at hours or even days to do an experiment. The decision to model at county level rather than UK level helped hide a very bad bug as well. So what were the advantages of their individual-based dynamic stochastic model over differential equations? It's not clear it was worth doing, not if you have to retract your paper. And it's not clear also that there are big advantages over an ABM here. So we've done replication, we're making good progress. Our model looks something like that. You can't download it yet, but you can download this one. This is called Networks and Unimix. This compares universal mixing with all other parameters the same, but spreading through a social network of your choice. And it's got all the usual choices in there, yeah, random, grids, small world, and so on. And what do we find? Well, we find that universal mixing overestimates peak cases. Everybody knows that. But I also created a network from some realistic contact data published by Stephen Kistler from the BBC 2018 pandemic project. And what's interesting is the network from that doesn't look like any of the library models of social networks. So if you're using any of them, maybe you're wrong. So yeah, that's it. Here's some references. Like I say, I will. The slides are up there on GitHub, and yeah, I will happily answer questions. And with that, I stop.
Thanks a lot, Christopher. I see there's only one question currently in the Google Doc. More may be added during the session. I suggest that you, during the session, add the links to the Google Doc, if that's okay for you. And with that, we can go to the next presenter. And I have to check my little notebook. And the next presenter would be Nick Malleson, who will talk about the microsimulation model of COVID spread in the UK.
Hello, yeah, I think that's right. That's what I was intending to talk about.
I think then, Nick, you can share while Christopher has to stop sharing.
Okay.
Stop share.
Does that look okay? Can you see the slide?
Yes, we see it in some kind of presenter view, though.
Yeah, okay, sorry, let me just... can you see that, or is that now?
Perfect.
Great, okay. I'll start my stopwatch. Thank you very much for giving me the time to talk today. I'm going to present on a microsimulation model that we've built, which we've tried to use to model the spread of COVID in the UK and ultimately advise policy. This is a collaboration between the University of Leeds and a number of other universities, none of which I've referenced properly, but I'll mention them at the end. A bit of background to the to where we started from. In the UK, the Royal Society put out a call for people to come and help with building models of the outbreak that ultimately might be able to feed into policy. And our contribution was to develop a national microsimulation model to try and look at how it would spread. And the collaboration is between the universities of Leeds, UCL, Cambridge, Exeter, and the Alan Turing Institute, which is the UK's National Centre for Data Science and AI. And this was kind of contextualized in the urban analytics program of the Alan Turing Institute. So what we wanted to do was take methods that we're all expert in and familiar with, and then try and use them to simulate the spread of COVID. So these were things like agent-based modeling, which come on to spatial interaction models, microsimulation, etc. These are all kind of technologies that we're all pretty comfortable with. We identified a few limits in the existing models. Many of them have quite a coarse spatial resolution. So these are models that work at city or regional levels. Abstract behavioral patterns, so things like circular catchment areas or distance, straight line distances. Often they have a commuting focus, so we wanted to capture some additional important activities and interactions. And in terms of demography or demographics, the models were often quite limited. So maybe age and sex would be the best that you would have. So we wanted something that was a bit, that represented individuals more richly. The features of the model that we've created are a reasonably good spatial resolution. So the spatial area that we're using is about 3,000 households. We have calibrated our mobility data to surveys, which we'll come on to. So it's an empirically based model. We're feeding data in at every stage where we can. The activities that we're modeling include retail, school, and work currently, and we're extending it to include other types of leisure as they become important. We need public transport in there, definitely, and we'd like to include things like hospital visits as well. In terms of demographic profiling, we've got rich employment, socioeconomic indicators, and health attributes as well. This is the overall structure of the model, and I'll talk about each of these in a little bit more detail shortly. But the way it works is in stage one, we start by creating a synthetic population of individuals and households. In stage two, we take that relatively coarse population and use propensity score matching to assign additional attributes. In stage three, we then, if we have the individual population and we have their likely behaviors, we need to estimate where those behaviors will take place. So we use spatial interaction models to do that. And then finally, in stage four, we actually run the disease model. So we seed COVID in the population, we allow them to go to the places that they will go to, and then we see how the disease spreads. So I'll just outline each of those in a little bit more detail. The first stage is creating the synthetic population, and we're drawing on a project called Spencer, which is a much larger project, and they're aiming to build synthetic populations that can be used to estimate the demand for infrastructure in the future. Spencer gives us an individual population broken down into households, and then we can also allocate them to dwellings, which we don't do. We keep all of the households at our area level. Stage 2 is to take that relatively coarse population and then link it to other data sets to enrich it. The data sets that we're using at the moment are a time use survey. This is for London at the moment, but we will expand it to a more representative survey. So attaching it to the time use survey gives us estimates of how much time people spend doing activities, so working, shopping, etc. We also attach it to the health survey of England, which gives us a whole raft of health characteristics which can be useful. Stage 3 is then to take that richer synthetic population and start to assign locations for where people will actually do their activities. So we know that these activities are important in determining which interactions occur, where they occur, and then how the disease might transmit. And we're doing that using spatial interaction models. These are origin destination based models. So for example, with shopping, we may have a number of people in an area, and we know what the shops are in the area, and we know how large they are, and the spatial interaction model starts to assign flows to those shops based on the attractiveness of each of the shops. And attractiveness might be something like the floor space, the type of shop. In schools, you might have the admission criteria of the school, etc. So we then have an individual synthetic population, people located in houses, a rich array of demographic and health attributes, and estimates of locations where activities will take place. That synthetic population is then given to this transition model where we can allow the disease to propagate. There are 2 stages to that. The first stage is to seed the model with COVID, because initially everyone starts disease-free. And the second stage is then, once COVID has been seeded into the model, we allow it to iterate on a daily time step. So people will visit shops and schools, etc. If they have the disease, they will allocate some hazards to that venue. Other people, when they visit that venue, then receive some exposure. And if the exposure is sufficient with some other variables, there's a chance of them contracting the disease or changing the disease, their current disease status. I'll just look at that process in a little bit more detail. So this is one synthetic individual. They have 4 activities. Most of the time they spend at home, and they spend 5% of their time going to shops. So if we look at how the hazard gets assigned to a shop, we take the proportion of time they spend shopping, which in this case is 5%. The spatial interaction model for this person has identified 4 shops which they may visit with different percentages. So if we look at shop 98, for example, that's quite a low one. That's only 7% chance that they'll visit that shop. So the hazard that gets attributed to venue 98 is some fraction of 0.05 times 0.07 with some weighting. And then when people visit venue 98, they can receive that fraction of exposure, again weighted to how much time they will spend in that shop. So it's probabilistic up to the point where we need to assign the disease, and then that bit then becomes discontinuous, because we anyway, I'll come to that. Very briefly, this is how the disease evolves. This was done by our colleagues in Exeter, who are the disease modelers. So I won't talk about the mechanisms. It's just important to say that the symptomatic stages are pre-symptomatic, asymptomatic, and symptomatic. So people only change their behavior in our model if they show symptoms. They can be carrying the disease around without having any symptoms, in which case they behave as they would do normally. Modelling lockdown is very important in a model like this, and the way that we've done that is we've looked at Google mobility data initially, and what we do is once lockdown begins in the UK, or in the run-up to lockdown, because people's behaviour did appear to start to change before that, we downscale all of the time away from home based on what Google have estimated from their tracking of our smartphones. So, for example, in the middle of April, when most people were spending time at home, we down-rated all of the other activities, shopping, working, leisure, etc., by some fraction of what we found in the Google mobility data. Here are some preliminary results, and the big health warning here is that we're still calibrating the model. We're not confident enough in these results to use them in policy yet, but I'm including them here just to show you that it's kind of doing as we would expect it to. So this is modelling Exeter, which is a relatively small part of the UK, and we will extend it to nationally later. And you can see the disease start to creep up and then drop down again once the lockdown changes kick in. And these are the kinds of cases that this is a similar trend that we actually saw in Exeter in terms of the daily number of cases, and it's calibrating to the Public Health England data. One scenario that we ran just to test it was to see if we started lockdown a week earlier, and as you might expect, the curve is much flatter because the disease didn't have the same chance to propagate through the population. Okay, I won't include any other results because it's still preliminary work, but what I will talk about is where we're going with it in the future. So initially we want to expand it to all areas of the UK. We're pretty much ready to expand it to England, but we haven't got data yet for Scotland, Northern Ireland, and we have some data for Wales, but not all of it because the different administrations have slightly different ways of managing their data. We would like to account properly for shielding in elderly and vulnerable populations, which we don't at the moment. They behave in the same ways that everyone else does. We need to account for key workers, and we'd also look at variations in risks in different types of activities. So work being more or less risky than going to school, for example. And these are things that are very easy to plug into the model just by changing weights, but I think data for some of these things is much harder. In terms of future scenarios, what we would like to look at are local outbreaks and local lockdowns. So the spatial granularity in the model is very good. So it's very easy for us to start looking at how you might either close all locations in an area or particular activities. We'd like to look at different shielding policies, impacts of reopening different venues. We'd like to start looking at how different healthiness might impact on the disease spreads. We could look at track and trace, and we're very interested in non-compliance with measures. So if people start to get bored, frankly, of government measures, how might that affect the spread? All of this is open source, so you can look at the code now. We have a couple of dashboards available on my colleague Natalie's GitHub page that you can look at. The health warning there is that they're using prototype simulations, so they're certainly not something that we would put out as useful in policy yet. And the documentation is available on the Open Science Foundation. It's currently closed because one of the data sets can't be made public, so I'm going to get rid of that, and then we can open up that page, which will open up all of the data and the documentation. And I'll put some links in the Google Docs. I'm sorry, I'm 16 seconds over.
Thanks a lot, Nick. Fantastic presentation, and even almost in time. 16 seconds is not much on a lifetime, I would say. With that, we are ready for presentation number 3 already. So we're really keeping speed here. Fredrik, you are also co-host, so you should be able to share your screen. And Fredrik will talk about the importance of contact patterns to counteract black box models. You're muted, Fredrik, but we see the screen.
Okay, so thank you very much. My idea with this talk is actually to sort of promote the idea that we know a lot of things about how different types of infections are, about the dynamics and what's affect the spread of society. And as always, it's important to remember that the model should be as simple as possible, but not too simple. And this is an example of what we know when it comes to how different structural properties of the network affect the spread. We know that variation number of contacts will speed up the press, and it will decrease the epidemic threshold. I will not go into every one of these, but at least we know what to look for when we want to understand why a simulation model behaves and gives the result as it gives. And we know also that the contact pattern in itself is more or less important for different types of infections. Highly infectious, like measles, for example, you can just assume random interaction. You may need to add some spatial component, but otherwise you don't need to run any more, add any complexity into the model. While analyzing sexually transmitted infection, it becomes much more complicated. And if we look at COVID-19, it should be somewhere here. It's not as complicated. Sorry, it should be here somewhere. SARS is more complex than COVID, for example. So, but one thing that is extremely important to remember is that we still miss a lot of parameters. We don't know the duration of infectiousness. We don't know how that infectiousness vary over time. We don't know if there are a big or small variation in infectiousness between different individual, age variation in infectiousness. We don't know if there are symptom-free infectivity and to what extent, and immunity is still a big black box. Will it just last for a few years, a few weeks, and will we have full immunity, or will it just decrease the risk for transmission? So that makes it extremely hard to model COVID-19, because if you look at Arnold, for example, that people just put into their models, it's extremely context dependent. So the goal with this modeling approach is actually to sort of map the parameter space that we are working with for COVID-19 or any other kind of infection. For example, this is just to show an example of if you work with household contacts, random contact, and workplace contacts at the same time, where in these parameters are we likely to be? Because we should not, at least from my point of view, work with point estimate. We should always work with simulation intervals. So what this model do, it extracts a network from spatial data and other kind of sources, and where we generate a contact network with different kinds of contacts, with different kinds of, that allows for different kinds of risk for transmission. So at the moment we are working with household contacts, workplace contacts, and societal contacts, where societal contacts are, we use a gravitational model, but we try different kinds of functional forms for that gravitational model. And one of the reasons for why we like this approach is that it's extremely, it's fast to run simulations, because this allows us to generate an ensemble of simulation, which makes it possible to somehow map the realistic parameter space. I'm not 100% sure that it's correct, but I heard someone say that the hygiene model took like 50 minutes to run or something like that. And if you want to do it seriously and also be able to sort of estimate the simulation interval, we need to run the whole simulation in 50 minutes and then change and adapt and try again. So here's just some preliminary results, and that it's possible to have a second wave within the parameter realistic, in a realistic parameter space in rural areas, which we've actually focused our research on. And it's also possible to have a larger second wave after lockdown in rural areas if you sort of use the same strategy as you do in more city-like areas. In the sense that you use the same lockdown strategy in different regions with both cities and rural areas. So this is just some example of what we've done before. So thank you very much.
Thank you, Fredrik. With that, we go to Jennifer Badham, and we'll talk about justified stories for local COVID-19 planning.
Hello, everyone. Can you see a screen that looks like a title slide?
No.
Yes.
Yes. Excellent. This will be a fairly brief overview, hopefully. This is some work I've been doing with Durham University. I've listed my collaborators there. I'm not going to do a demo or anything, but this is basically just a screenshot to show you what the interface looks like. The general idea of this was to create something that local planners could use. It ended up that we're doing all of the simulation runs, principally because they're not they can't install the SoftNet logo onto their machines for IT reasons. So the model is about being a tool for thinking. So what we're trying to do is do a rigorous extrapolation of knowledge about COVID-19 so that planners can ask questions of interest to them rather than receiving centrally generated reports and data summaries. So on the right here is some sample questions that they've been asking. Based on local prevalence at a particular time point, what is the likely prevalence at the end of a lockdown period? When would the second wave occur with different track and trace assumptions? That's the one that I've plotted out here. What happens if you've sort of got a sequence of outbreak, local lockdowns, then complacency, another outbreak and things like that? So what does that sort of sequence, what's a plausible set of sequences for that? What's the probability that a lockdown would have actually successfully eliminated COVID if you exclude imported cases? And what has been achieved by lockdown? So as part of the messages for local government to be able to say to people, this is what you've been doing. So like all other COVID models, you know, there's an extended disease, SEIR disease transition process, so susceptible, exposed, infection in the community. Some cases become severe, some cases become more severe, and people can die or become immune from any of those infectious states. The transmission process is very rough and ready. So basically it's spatially oriented. You've got a grid of 41 by 41 patches. Each starts with 12 people, and they can expose, an infected person can expose susceptible people on the same patch, and people move around. So here we've got you know, this little area zoomed in. The blue dart is a susceptible person. They become exposed the next day. The large orange are the infectious people, and this blue dart wasn't there before. Some people are moving. So this is there's no relationship really to a real transmission process. To set the parameter values, there's some built-in stuff that's epidemiology based. So the transition process has probabilities and duration distributions that are taken from public data in the UK. The transmission process, the reason that there are 12 people on each patch is because the literature says that, you know, there's an average of 11 daily contacts in normal activity. And then what we did was the three parameters for the transmission model were calibrated by fitting to a standard system dynamics compartment model that reflected the best interpretation of how COVID was spreading back in March when it was started. So then on the user control side, there's no calibration list. What the model is doing is bringing in policy scenarios that have parameters that are set to the user's judgment, because what the tool is for is to allow people to explore what would happen if. But the idea is that you can have combinations of policies. So you can have, you know, a short period of lockdown and then gradually increasing the track and trace the proportion of people who are complying with track and trace and so on. You can change the main epidemiology parameters in the interface, such as the probability of death and so on. But they're really coming from data. So the policy options in the model are bed blocking, so there's a higher probability of death if no hospital bed is available. Reducing activity, things like closing public places and so on, that really operates on the probability of transmission. Reducing the transmission, things like hand hygiene and face masks. Shielding those at higher risk, basically a certain proportion of the population are treated as if they're isolated, and reducing movement. And then you can also have some track and trace type things that if people become symptomatic, they can inform their contacts and they can choose to isolate. So all of those options are in there. They can be applied a little bit, both in parallel and in series. So the point of this is to generate justified stories, what we're calling justified stories. So by this intentionally refers to stories as sequences of events that are coherent and internally consistent. And they're justified because the model represents the knowledge about the world, the data, the theory, the expert opinion. So that provides an external consistency or plausibility. And the model is very much embedded and framed by this description purpose, that it's not designed to explain or predict, but to represent and formalize some of the relationships and dynamics of the situation. So essentially the model is providing convenient access to knowledge that is organized in the model. Harko asked us to reflect on a few things, so I can actually follow instructions, and that's at the end of what can the model speak? Well, basically it counts epidemic states over time. It combines policy options, so you've got lots of little effects with different timing, and it can give you a handle on levels of uncertainty. It's very much intended as a tool for thinking, because local government in the UK have lots of responsibilities for managing, but have limited control or relevant experience. So it's a tool to help them gain some experience quickly. What is not in the model, but I would include if I could? Well, the population is 20,000 agents, essentially for performance reasons. It would be nice to have, a full population, but that would make it unworkable. I don't have any age structure in there. At the time I designed this, the transmission risk gradient was unknown. So there didn't seem a lot of point in having an age structure, but I would put it in now if I had the time to put it in. And it would be nice to have a contact network, because that would allow different policy options to be explored. Things like you can only, things like bubbles. What I've excluded intentionally, and I wouldn't put in even if I did have the time, high resolution transmission. This is mostly because we don't know what the risk is. There's little point in including a whole bunch of really rich workplaces and transport if we don't actually know what the risk is that's associated with that. And those are undetermined for calibration purposes. So I've basically just said, well, if I'm going to be calibrating at a fairly rough level anyway, then I don't need that much detail in the model. And the other thing that I've excluded is the social effects of policies. We know that there are, mental health issues, for example, associated with lockdown. That's part of the policy discussion. The model says, this many people need to be locked down, but then the debate about whether that's an appropriate policy needs to happen at the ethical, explicit discussion about whether that policy should be introduced. This model only focuses on the effect on the epidemic. So it's not, that sort of trade-off is not hidden in the model assumptions. And that's it.
Thanks a lot, Jen. And then we have the final speaker of this session, Imran Mahmood, who will talk about comparing ABM approach with conventional approaches in disease modeling. And that would kind of like wrap up the whole session, I would say. We see the slides, but the mic is not on, Imran.
Hi everyone, can you hear me now?
Yes, but now we see the slide in the edit. Yes, there we go. We have the slideshow and we hear you. Go ahead.
Okay. So I'm going to talk about COVID-19 simulation using FACT simulator that we recently have developed. I am Imran Mahmood and I am from Brunel University, London. In this short period, I will be only able to just do an overview, though we have a lot of details to share, but I guess for now, it should be the overview. So the motivation was to have work on COVID-19 outbreak. Most of the existing models are at national level. There is a need to forecast the spread of coronavirus at a greater resolution, particularly subnational regions. Location-specific public health interventions need to be evaluated. For example, enactment, lifting, or reenactment of the lockdowns. Local location-specific healthcare operation readiness needs to be studied. For example, capacity and the patient flows in healthcare points. So we developed a FACT simulator, which is basically a composition of agent-based modeling approach, OpenStreetMap data, high-performance computing, and open-source Python code. So the recent publication on this simulator and its technical details are available in this paper. I'll just give you an overview of the architecture and the steps that are used to make this simulation work. So we have a situation selection mode where the region and the time period of the simulation can be selected. We currently focused on borough level in London, and in parallel, we are also doing a large-scale simulation of the entire Madrid city. In the next step, the data sets that we input into the simulation code is the OSM files, the geospatial networks, which are basically used for location routes, so that the mobility of agents is based on networks, the epidemiology data, and the construction of the disease model, in this case, the COVID-19 disease model, and the demographic data, which is basically to inject the behavioral patterns and the daily life movements of the agents in a population. And it is a contextualized data set, which is basically the age distributions and the movement patterns and the length of stays at different types of buildings. So once the model is constructed, so our code is basically able to parse the OSM files and create a location graph, which is basically different types of buildings. I will be able to show you a screenshot on that. The location routes are basically extracted to do the shortest path finding between different buildings and the agent movement selection. Disease model is focusing on the infection rate and all the different disease parameters, the incubation period and different parameters. Similarly, the behavior patterns are the needs of people to go to different places during the day and their length of stay. In the refinement stage, the lockdown measures and different types of healthcare interventions are evaluated and modeled and evaluated. In the execution stage, we can either run the code on the local machine, or we can use supercomputing using our FABSIM framework, which can help run the remote supercomputing simulations. So far, we are able to scale a population of up to 6.8 million, which is a population of Madrid city. So this is basically using supercomputing. And the final stage is to do the visualization and the validation of the results. My focus of the talk is basically comparison of disease modeling approach. So that's why having a detailed technical discussion on facts might have to, wait. So first, and the traditional approaches are the mathematical model. Disease epidemics have been traditionally modeled using mathematical equation. For example, the SEER models that use ordinary differential equation, they are basically limited because they work on a large population at an aggregate level, have significant limitation. For example, they treat the system components as homogeneous entities. Similarly, another approach is system dynamics that uses talks, flows, feedback loops, and time delays. They also they represent the entities as numerical quantities, and they are a macro level model. The dynamics of disease spread can only be implemented on a cohort as a whole using centralized mathematical formula or instruction set. The discrete event simulation are typically used to model processes and operation of a system. For example, hospital paths, workflows. However, this has been applied in the epidemiological context in the literature. Focus is on the process, not the entity, which I would call it a limitation. It's a top-down monolithic logic, for example, single centralized thread of control. Data-driven approaches like Bayesian inference, regression modeling, and machine learning are solely dependent on the data. cannot perform well when only sparse data is at hand, which is currently the case of COVID. Partial knowledge of underlying phenomena, again the case of COVID, because the knowledge of COVID is still evolving and developing. Knowledge about COVID evolve over time. So this approach is basically limited because of these factors. Agent-based modeling captures the property of complex disease dynamics at a fine-grained resolution. It express properties of complex systems, which are hierarchical forms, collective behavior, evolution, adaptation, spatial networks. Population of individual agents have own characteristics and behavior, which is a very sophisticated feature. Own situation and decisions, own set of rules. Heterogeneity is there with statistical individual behavior. So agent-based modeling is quite rich in doing disease modeling. And then there is a whole process of emergence. However, existing ABM disease models are still limited. We identify these limited features. For example, limit use of spatial data for the model construction, limited or no use of demographic patterns, simplistic disease transmission rule sets, limited abstraction of public health measures. Execution performance bottleneck, a lot of them. Limitation of scale. So these were basically the existing limitation in ABM frameworks. We identify them and we try to address them using facts. So basically I will give a brief on different components. Facts has a pre-processing module, which is basically used to create location graph, input disease files as YAML input files, demography data can be prepared. Then the post-processing module is used for visualization and the validation. And then there is a FabSim COVID plugin, which is basically used to interface the simulator with the remote supercomputing environment to scale up the simulation runs, and a lot of replicas can be executed. Unique features include the open-ended platform in Python that helps in modeling agents with freedom of code, virtual environment configuration, and rule sets. Systematic simulation development approach, generalized disease modeling. So these are allows the non-programmer to use as a suite for disease modeling, like epidemiologists can use it, and the programmers can use it for open-ended API and do scientific research. It also uses Eagle supercomputing, provides execution platform. So supported feature, I can summarize it here. Public intervention measures that are supported, lockdowns of different kinds, school closures, and then their percentages can be selected, work closures or reopening, shops closure, leisure closure, gyms, playgrounds, amenities, percentage of population wearing masks. So we can actually select that, and then we can evaluate those safety conditions. Similarly, transportation use, the testing and tracking, airborne transmission. So these are the features, and we are also doing development on social distance compliance, transmission model with confined spaces. So these things are the current features. I will give you a glimpse of the simulation result that we have obtained so far for 3 boroughs in London, which is Brent, Ealing, and Harrow. So these are the susceptible readings for different 4 types of lockdowns. For example, extend lockdown is the default scenario that we use. Then this is the exposed results. We are getting a peak of roughly 1,000 cases in this scenario. We have a peak of roughly 60K infections in the boroughs under extend lockdown, and then these are the recovery and the deaths. Let me show you a little bit of an animation that we created for the visualization of the spread of cases in Brent borough. And these cases are scattered, distributed based on the types of the buildings in which the cases arrive. So you can see that the Brent borough is basically showing the simulated arrival of cases, and the southern part of the Brent is more concentrated, and most of the building which is showing cases is houses. Sorry. So that's it. Thank you very much. We have the whole team that has contributed in this research, and I wanted to acknowledge their names. That's all from my side.
Thanks a lot, Imran. That was the final presentation in this session, and according to my time, just a few minutes over time with each, I think, an accomplishment for all the speakers. I would now like to invite all speakers to pick one of the questions that are posted them in the Google Doc and answer them from the first presenter to the last, because the last presenter just presented has had no time to see the Google Doc. And after that, we will see if we have time for a general question, because that box is slightly empty currently. And if it is some time available, I will pick the general question. So, Christopher, can you pick your favorite question to address in a live interview on top of the
Okay.
Google Doc?
Okay, so I've got Mike some question about yes, how we can make estimates for the UK when we're simulating London boroughs independently of each other and simulating them independently of all the other counties in the country. And I think that's a very good question. That's what struck my modeling team as well. So yeah, basically they are simulating all these things running independently. There's no cross-border infections. I was born in a town where a large proportion of the population commute up to London, about 50 miles away. So yeah, I think that's a very good question. But think back in February, nobody has a network model or a contact model for the UK as a whole. So nobody knows really how to do better at that stage. But we've got all these track and trace apps. The UK one's working really badly, but other countries will have genuine contact data soon. So some future pandemic, we should do so much better.
Thanks a lot, Christopher. Nick, do you have a favorite question in the Google Doc that you would like to address?
I do, but I'm afraid I'm going to spin it around and ask a question myself. Mike Bithell asked a very short question. Is there any accounting for surface contamination? So I take this to mean when we do meet people in places, can we account for the different ways that the disease is spread, droplets or surface contamination? The question is, no, we don't include that in the model, but it is something that we could include relatively easily because we have people visiting places and interacting with each other. But the big problem that we've come up against and again with this kind of model is where we get the data from. So it's all very well that we can estimate, I think reasonably well, which places people are likely to go to. So, we can estimate which shops people go to, but once they're there, how do we put numbers on the probabilities of the disease being transmitted? And that's the big hole at the moment, certainly in our work. So if anyone, well, I'll leave that there.
Thanks a lot, Nick. Indeed, I think that's a pertinent message during all the presentations is do we have the data to do the magic that we want to do in our modules? Fredrik, do you have a favorite question or something you would like to address?
Yeah, I have not a specific question, but that is something that I would really like to address. And that is, I think that people seem to very focus on to get real actual data. And yes, that would be a good idea. That would be important if you were looking at HIV or tuberculosis, for example, where you really need to know who's interact with who and where are they go. Are there a specific outbreak in this specific bar and so on. But the problem with COVID-19 is that it's much closer to measles. So there are so much random here. So we will, as long as we don't know more about how contagious this infection is, and so there's actually, just to say, a model should be simple, but not too simple. But it should not be too complex either. Especially, I think it's important to have some kind of equilibrium between all different dimensions of assumptions. So, and I really encourage you all to just take a quick look at what's have been done, just to see what's the problem and what's not the problem is. Okay, thank you.
Thanks, Fredrik. Jen, your shot.
Okay. I think, having a look at the questions, I think something that makes people uncomfortable is my really bad transmission process. That, you know, I've got completely imaginary three parameters. One is the probability of transmission, and then there's two movement parameters. Okay, and that leads to the population mixing. There's no attempt for people to return back to their home patch or anything like that. And yes, it is true that that is terrible rubbish, but there are three parameters in that. And what I have done is calibrated that to running my model unmitigated, running their model unmitigated, calibrated that to a standard compartment model, system dynamics, and that is fitted to genuine epidemic spread. So it's not that I've used their R0 equals 3 number or whatever. They have fitted their epidemic model to the epidemic spread. And that includes, you know, whatever the contact patterns are in that population, the health of that population, the changes in behaviour, that, you know, as people are scared, they reduce their interaction. All of that is captured in the observed data about epidemic spread in that population. And so all of that is automatically captured in their fitted model. And then I've created a transmission process that replicates the effect of that transmission, but not the process by which it's achieved. Hopefully that makes it a bit clearer what I've done.
It makes it clear to me, at least, and I hope I can be the measure of the general audience in this workshop. Then we go to Imran.
Yeah, thank you. I have received two main questions. I'll address them both. I have also added the answers there. So one is the geospatial network. How do we get that? So we are using OSM Nix Python package, which is basically library to import the OSM data and create networks. We are doing point-to-point processing of different nodes and using, for example, shortest path algorithms, things like that. But this feature is still under development and not the part of our first release. It's going to be the part of the next release. The second question was about the OSM data and its issues and a lot of errors in that. So yes, there are a lot of issues with the OSM data. It's a crowdsourced public data set. So we have been able to do basic debugging and algorithmic improvisation of this data when we find some problems in parsing different nodes. But we also plan in future to do a crowdsourcing in the student body of Brunel University to create some tags. So I would say that it's not the best choice, but still it is something better than nothing.
Thanks a lot, Imran. As we are slightly late and we have so many things to do, I will skip the general questions that are being produced, and maybe we can wrap them up at the end of the whole workshop even. And then we can now have a short 5-minute break. I will pause the recording and we'll see you in 5 minutes.
Screen and couldn't.
Okay, I'm gonna enable you and start the recording again, and I just have to find you. I see 2 Nicks, but I don't see Nick Gotts. There we go. Yep. Here you go. Now you are allowed.
No, doesn't work.
Doesn't work?
No, I'm clicking on share screen. Nothing's happening.
However, you are co-host. I see Bruce is now taking over in my view.
Hey? Oh, wait a minute. I'm now getting select a window you want to share.
There you go.
That's
a good sign.
Ah, here we are.
Good. Go ahead, Nick.
Okay, So I'm going to talk about the agent-based modeling in the SAFER project. Here's a little bit about the SAFER project. You can see where the acronym comes from. The formal title of the project is in the second line there, COVID-19, healthcare workers, etc., etc. But we all call it SAFER. Funded by the MRC, various 3 partners, UCLH, UCL, and the University of Leeds. And it runs for 18 months, but we got an application in for an extension. Now, for 12 weeks during the outbreak, staff in the hospital in UCLH were virus tested weekly, and a subset of staff filled in a survey about their behaviours and attitudes with regard to COVID-19, and a subset of that subset took part in extended interviews. So we've got that data to use. Agent-based modelling is a pretty small part of the project. We only started in July. So our focus is likely to be COVID-19 transmission within some specific wards within the hospital, probably the intensive care unit and haematology. Modelling aims, well, we want to produce scenarios which will be characterised by estimates of transmission in a range of circumstances. We will probably need quite a lot of scenarios to account for the degree of uncertainty about, for example, how well the virus transmits via surfaces that produce similar patterns of staff infection to those in the data. To identify the transmission risk parameters with the greatest effect on these patterns, so helping people to decide where further research should take place. Propose behavioural changes for the staff likely to reduce transmission risks without unduly hampering them, and propose policy measures for the administration most likely to reduce the probabilities of infection in the case of a second wave. That might mean, for example, changing the rostering patterns or bed density and so on. The model is going to be structured as if you like, a set of layers. At the bottom layer, there will be what are called everyday ward routines. Hospital life is highly stereotyped at this level. A lot of things are going on every day. I've listed some of them there, and I won't go through them all, but they involve most prominently nurses and nursing assistants. They're there all the time. Also, of course, doctors doing their ward rounds, other health professionals, psychologists, and so forth. And of course, cleaners, porters, people who bring round drinks, trolleys, and so on, and visitors. Then we've got what I've called planned event routines, things like patients going for surgery, for imaging procedures, and of course discharge. So these will be planned in advance, but they won't be happening every day to all patients at fixed times. Then we've got unplanned but nevertheless planned for event routines, such as medical emergencies, such as the need for resuscitation, security incidents, such as a patient or I suppose a doctor becoming violent, and finally unplanned for events and the disruption of routines, which would very much have been the case at the beginning of the epidemic. But as time goes on, new routines or modified routines would be implemented, and we need to try and model the process of bringing in new routines. Here's a lot of the data that we've got other than the survey and the interviews that I mentioned. UCLH has a fairly extensive electronic record system. On the left, we've got here the basic staff database. Then in blue, I've got sources of information about where staff, that is mainly doctors and nurses, not unfortunately cleaners, porters and so on, will be at particular times. The staff roster, that would include cleaners and porters. Door access, a lot of the staff have door access cards so they can get through locked doors, and the times at which they went through a particular door is recorded. And finally, we'll need floor plans of the hospital. Then the biggest source of information is EPIC. That's it's the electronic health records system, which includes is intended to include every significant interaction between a doctor or nurse and a patient. So we'd know which patient it is, what is known about their COVID status, the time of the interaction, where it happened, what type of interaction it was, whether it's taking blood, giving medication, and so on. And finally, we have information about the staff's COVID status from the data I was talking about. Using all this information, we'll first come up with a database of events, including information from several of these sources. You can see what we're including there. And then going on from that, databases of staff-patient interactions and staff-staff interactions. So we can try and assess where virus transmission is likely to have occurred. One of the main questions we have is what sort of detail, what sort of level of detail we need to represent the ward. We don't yet have floor plans of the UCLH ward, so I've used one here of the Prince of Wales Hospital in Hong Kong, where there was a study about how SARS was transmitted to healthcare workers during the epidemic in 2002 to 3. We will certainly need the ward's two-dimensional layout and staff's habitual paths from place to place. And it's unlikely we'll have the data and resources to use a full three-dimensional representation or to model airflow in detail. Airflow may be quite important, but there's usually very little data on it. So what we may be able to use is an intermediate level of detail with what's sometimes called a 2.5 dimensional representation of space, where the height dimension is divided into a set of layers. So that might be floor, below bed level, at bed level, above bed level, but within reach and above reach. And in each of those, you might have surfaces and objects which can possibly transmit the virus. And possibly a set of airflow zones defined in relation to inflows and outflows of air across the ward. So at what level of detail do we need to represent, represent the virus? We do need to think about transmission routes, obviously, and we may need multiple scenarios to cope with uncertainties such as that of transmission via surfaces. The course of the illness, we need to represent the turnover of patients, transfer to and from the intensive care unit, and in particular aerosol generating procedures, which are thought to be particularly dangerous. But we won't need the kind of pathophysiological detail in that pretty picture. Genetic differences between virus samples. We will need to represent, if we can, how many distinct introductions of the virus into the hospital there have been, and that information you can potentially get from the data that the virologists are collecting. And variation in levels of infectivity across individuals and over time. And also, of course, what diagnostic tests have been done. So patients and staff will have both an actual COVID state and a diagnostic state, representing what is known or believed about whether they're infected. So in summary, we propose focusing on the roles and routines of staff, that is healthcare workers and patients and visitors in the life of the ward, as I expressed it. And in the context of COVID-19, this means modelling interactions between people, pathogen, and the physical and institutional hospital and ward environments to identify likely routes of viral transmission. So in a way, we're working backwards towards the data we've got about who became infected when, from assumptions about how transmission occurs. And then we have multiple data sources, as I've laid out, on staff activities and movements to inform the model. And a key question for us is determining the useful and practical level of detail that wish to model every aspect of this complex of factors and interactions, particularly as we're quite limited in time and resources. Thank you.
Thanks a lot, Nick. And we go to the second presentation, Alexis Drogoul, who will present the COMO-KIT model. Alexis, you should already be co-host. I see your screen. Yep.
Okay, so you should, is it okay here?
We see the presenter view.
Okay.
So we see what you see as in I have so many minutes left.
Ah.
You don't see the slideshow as such.
Okay, let me just, okay, give me 1 second. Is it better here?
Now it is totally white on my end.
Okay, so.
There we go. Now we see the slideshow, and now we see you and not the slideshow.
Sorry. Okay, let me check. Let me do it again. It should be okay this time. Is it okay now?
Yes, perfect. Go ahead, Alexis.
Sorry for that. Yeah, so thank you very much for organizing this session, and also to give me a chance to present the COMO-KIT model. Actually, it's we've seen really fantastic models before, and actually you will see that these COMO-KIT model shares a lot with the ones we have been presented so far. Maybe the only difference is that in that case, first we are relying on very unreliable data to build this model. You will see it's a model built in Vietnam, where it's sometimes difficult to get the data you want to have for a model, and also that actually it is being used on a, let's say, daily basis by the Vietnamese government right now. So it's a work done in common with colleagues from Laos, Hong Kong, France, of course, and Vietnam, who were the main contributors. So just to make you travel a little bit, because I know it's complicated right now in the world, to make you travel a little bit, Vietnam is a very peculiar situation with respect to what we can see in Europe and probably elsewhere in the world, maybe not in Asia, but so you have 95 million inhabitants and only 1,000 detected cases, and so far 35 deaths. And we didn't have any new communicated cases for 20 days. You don't have any restrictions except at borders. The country is completely closed, and that's part of the policy of the government. So it has been so far since late January, actually. It has been what we might call a low-cost strategy, quite realistic, actually, given the possibilities for hospitals here to host people. So closing of borders, systematic quarantines of people coming in, schools closed for roughly 5 months. They have reopened in April. Mandatory masks everywhere, in public and private places, actually. Very focused tests and a lot of tracing strategies. So we are in a country where the state is quite strong, okay? It's still a socialist country. And actually a lot of, I would say, local organization is present here. So either by the Communist Party or by what we might call the district committees. Okay. And so the main strategy of the government has been to organize localized containments, localized lockdowns, very localized, with a scale which was considered as manageable by the local authorities. So what we call in Vietnam the commune level. And commune level is roughly 10,000 inhabitants. Okay, so in a rural area, it will be the gathering of several villages. in a urban area, well, it's a little bit less than a district, much less than a district actually in Hanoi, for example. So the goal of ComoKit from the beginning, and we were contacted very early by the Ministry of Health here, was to support public authorities in Vietnam by developing a model for assessing but also comparing different mitigation policies at the level of communes. So at this level, okay? And it has been already said, so I will go very fast. At this scale, spatial aspects and individual and social heterogeneities are key factors to take into account if you want to understand actually what some failures or successes of some specific mitigation policies. So of course, one of the ways, it's not the only one, but one of the best way to represent these individual properties and play with them and also take them into account is by designing and simulating agent-based models, okay, where the profiles of people, households, the interaction in evolution in time and space, are explicitly represented and serve, well, actually as a basis for describing the dynamics of the epidemic. So ComoKit is organized around a very, I would say classical now. It's terrible to say this, but very classical epidemiological agent-based model, where you have individuals at the center of the model. You have a representation of space, which mainly considers buildings, okay, and places where people can gather. And then a representation of the authorities and local authorities, which can manage, so authorities can manage policies and can implement policies. These policies with role will mainly be to restrict, constrain, or maybe favor some activities that can be done and that can be implemented by individuals, okay? And these activities are organized in agendas, which can be either input into the model or generated, okay, from actual data. So the data we are using here, and we put a special focus on this, was there is some difficulty in Vietnam right now, in Vietnam now to get actual data, whether spatial or social data, demographic data. So we implemented some, I would say, pre-processing modules, allowing people to enter Google Maps or OSM data, and use also the possibility to generate synthetic populations, either from a synthetic population generator called GenStar, or directly using heuristic rules regarding the, I would say, the structure of the Vietnamese demography. Okay, so the epidemiological submodel, which is implemented within each individual, is again something you have already seen mostly except maybe for some details in the previous presentation. So it's an SERI model with some, well, infectious states which are characterized by the fact that people can be pre-symptomatic, asymptomatic, or symptomatic. And also all the states when people are hospitalized are taken into account here. So people needing ICU, people needing hospitalization as well, and which might be recovered or unfortunately dead. The policy submodel is based on the design of an authority agent, as I said, and actually it's designed in such a way that people can very easily compose policies. Okay, so you can very, very easily build policies that will be the compound of a number of other policies. So restricting the mobility of people, or closing schools, or detection policies, hospitalization policies, etc., etc. So these are being designed by discussing, actually, mainly discussing with Vietnamese authorities and trying to find the best way to represent them so that people can build and compose them. Okay, so it was one of the points we put the focus on in ComoKit. So actually, so here it's a very very easy, and it was part of the first tests we conducted with ComoKit. So it's the example of a realistic lockdown policy. So you have actually the composition of many different policies here. Locking schools, all the positive cases are locked down at home. You allow only 10% of workers to go to work, and 100% of the non-positive cases are allowed to go shopping once a day. Okay, so that's an example of the kind of policies we can conduct using, we can design actually using ComoKit. Another example here, it's the same realistic lockdown policies, but with different durations of lockdown, okay? So with detection policies at a rate of 20 tests a day, etc., etc. And all these examples were actually done in a very specific case study in Vietnam, which happened to be one of the first outbreaks in the country. So ComoKit is both a model we are using in Vietnam, but also a model which is which can be used as a basis for building others. Okay, so it can be forked, it can be modified. You will find it at comokit.org on the website. It can be directly applied to new case studies and given case studies. We are working right now to enhance this model and the framework itself. We have taken into account upscaling techniques. So there have been very interesting talks just before. Addition of realistic urban fluxes, urban flows on transportation, for example, which is not taken into account here. Addition of more detailed activities, other infectious diseases, and the interaction between them. And of course, coupling with existing models, which is a kind of challenge here. Actually, on the design of smart and resilient cities to future pandemics. Something that maybe is is very important for us, and it has been a great source of feedback. But of course, there are many trade-offs and many precautions to take. We have to be very cautious on this, but actually ComoKit is now used on a continuous basis together with other models. So there are many different models used by the rapid response team of the steering committee against COVID-19 of the Vietnamese Ministry of Health. But it is important to have this kind of feedback. Okay, so we have had people being able to study some outbreak cases in Vietnam using ComoKit and study the impact of different mitigation policies. So probably they did not take this, and I don't have all the details, but they did not take this as the only source of information. I hope so. But at least it allowed them to very easily, in less than 1 day, actually, they were able to build a complete case study on using ComoKit and simulate different outcomes of applying different policies on this. So that's it. Thank you very much. I hope I've not been too long. I don't know, actually. I don't have no clock here. So thanks a lot. Please ask me questions on the Google Doc. Send me mails if you want. You have my address here. And also the site where ComoKit is available is, of course, open to everyone. Thank you very much.
Thanks a lot, Alexis. With no further ado, we move to the third and final speaker of this session. Frank Dignam from Durham University will talk about the asset model. Frank.
Trying to get things going. Let me see if this works. I hope you can see this a little bit.
Yep, good for me.
Okay. So yeah, this an effort of a whole team of people, actually, mostly in Sweden, but also in the Netherlands. And basically, there's no this was a project started in February, all voluntary work, actually next to other work that people were doing. So it's kind of interesting process as well. What I actually want to focus on in this very short talk is what we did different from all the other models that we see before. And actually, I was just thinking the best to illustrate this is if you have a policy of closing schools, you don't have children that then defy that policy and go to school anyway. But if you lock down, so people are supposed to stay home, or they have to be in quarantine for 2 weeks if they're tested positive, people can actually violate that restriction. So some of the restrictions are pretty well controllable and other ones are not. And actually what we wanted to take into account is what happens if people are restricted, how will they behave differently, and how will that impact the result of all those restrictions. And in order to do that, we built the agent-based model on this kind of principle background. So we start with the value systems of the people, which basically determine their outlook. And to prevent some questions, these value systems are different in different cultures, so we also have different culture models. And then you have the basic motives that people have. They want to associate with other people, they want to achieve some goals and all that. There are affordances in environment, so you can do things at school that you cannot do at home and the other way around. So that all is mediated through institutions and organizations and all that kind of social stuff, and that leads to different actions. So this is the kind of background idea of the whole model. So the value system actually is based on the Schwartz value system, but then also made precise in getting to all kinds of specific actions that will support different values. So per value, you have different actions that actually satisfy that kind of value. So that's how it ties into the daily life of people. So making that precise, it was easier to do that through something like a need model that we already had, where the needs like the need for power or the need for benevolence or the need for conformity, they're seen as a kind of containers. It's a thing that slowly depletes, and actions that support that, they will fill the container back again. So it means that you can try to balance the actions such that all of the needs are more or less satisfied, but you never want to get it completely empty, but there is a kind of threshold where it starts getting some attraction for action. So this we used to combine different things. So we also have this epidemiological model, and we started off with a quite simple model in February, and then later on we updated that, and we got a quite complex model that's based on epidemiological model from Oxford. So we actually put quite some effort. That actually in the end the results were not very different when you use this very complex model than when you used a simple model. And the other thing that we need to incorporate was economic model. So people need to go to work to get money. So that has to do with will people still go to, for instance, a workplace where they cannot work at home, but they have to be at a workplace, while they also fear to get contaminated with the virus. So how do they balance that? Do they call in sick, even if they're not sick, or will they go to work? So that's the kind of things that we needed to have this economic model for as well. The whole system is then built on this thing. So the agent, it lives in an environment. The environment is more or less a kind of small town. The agents have a general profile which has the age of the health of the agent, the home where they live together with other people or not, available actions that they have in different places, and there is a social profile of the agent that determines whether it will keep, for instance, social distance, or it will not think that's very important, how risk avoidance they are. You get an epistemic model. Do they know they are sick, or do they don't know whether they're sick? So if they're not symptomatic, they might not know that they have the virus, but after testing they should know. And there is this needs model, which actually then we make 3 types of things: the social needs for belonging, compliance, conformity; psychological needs to have some leisure, some relaxation, but also being autonomous, so make your own decisions; and survival needs, you need food and you need a home and you need some safety. So all of that goes into this deliberation function, leads to action that actually changed the world again. So already some people talked about data and calibration. What we actually have for data is daily life patterns, which are basically based on common sense. People go to work, go to home, go to the shops, have some leisure in pubs and visiting other people, go to birthday parties and all that. Then they have to do that based on their needs. So the amount of things that I do is all based on needs, and we calibrate that such that a normal life where people sleep, go to work, come back, or go to school, go to the shops every now and then, satisfies the needs of all the agents, and the economy is balanced. So that takes some effort, but that's actually the kind of basic cycle that validates what's happening. Then we have the number of shops, schools, and all that based on real numbers. So we look a bit on demographics, and we adjusted that for what we call the context purposes. So we don't have one supermarket, which then is kind of not very clear how many people you would meet and how that would scale up if you go from 1,000 to 5,000 agents. So we have more small shops that we can then determine per shop how many people normally meet in a shop. And so that we have a number of contact points where people get to, and then for each of the types of points, we get how easy it is to be contaminated in that point. Then we have the agent profile, so the ages of agents, their whether they live together or the types of households, and that's all based on census data per different country. So we have data and some validation, but it's all based on very pretty high-level data sources. So our purpose was to support people having to make policies. So what we wanted is to create scenarios, analyze the results, and having some interactivity, so you could actually easily change some parameters. And there should be something like incomplete or fundaments of a model. So you should not have everything fixed for one simulation, but you should be able per scenario to fill in the different parameters in different ways based on, for instance, countries or situations that you want to check. So in order to get that working, we actually built an interface in Unity. And so this is a slightly old version of it, but it's easier to show that on the slide. So you have here the town where you have all the different locations where people can be. Here in the center you see there are shops, and there can be, I think the green one is the hospital. So you can see people moving around. And you see the red locations are locations where people are infected. And there are a number of things here in the bottom that you can easily keep track on. So then you see how many people are shopping, how many people are infected, and all that. So that gives you already some idea about what's happening, but actually we needed a lot more analysis. So we have things like infection trees. So you see this person is infected, and it infected a number of other persons. And in this case, there are these squares and ellipses. They indicate the type of other agents, so whether they're of a certain age or a certain type, whether they're children or retired people. And this also gives you a kind of a trace of how infections work. And looking at a tree like this, you see that, well, actually it stopped more or less here, and then here started a second wave in the bottom. So it gives you a different type of perspective on the same data. Similarly, we looked for track and tracing apps. So how did that work for app users and non-app users? So how is it infected? The infected non-app users and infected app users. So you see how many people are infected and how many people are infected between the non and the app users. And at a certain moment, it's very easy in this kind of interface to see, oh, there's actually most of the people that are infected don't use the app, and therefore it's very clear that you don't really get a lot of results from an app that does the track and tracing. So we built quite a number of this kind of interface for the analysis, and this actually shows the NetLogo interface that we have for building the simulation. And if you look at that, this kind of we made it small to fit on the slide, but of course this is not usable in practice for any user anymore. I think we have over 150 to 200 variables that you can set, and it's completely impossible to work through an interface like this. So we need a lot more different types of interfaces. So we started working not in simulations but in scenarios, and in each of the scenarios we see dependencies between different aspects: health, social, psychological and economic aspects. And what we do is we test different instruments, different measures, and find balances between the different aspects. So if we close the school, what's the effect of that? Does it weigh against the benefits that you have? What happens when people all start work at home? Does that actually have a big effect? So what's the effect on number of people going to hospitals and all that? So we did a number of scenarios with all the results there on our website. Currently, we're also looking at exit strategies. What are the kind of measures to, what kind of way can we lift restrictions, in what kind of combinations should we lift the restrictions, and what are the different effects for that? And especially also what are economic consequences, both in the short and the long run. So a lot of the things are about what if, and trying to find different combinations. So just a small thing about simulations, actually, that set off a lot of the rest, is our result on the track and tracing app is this one. So after we used the epidemiological model of the Oxford people, they said if we use track and tracing apps, then this is the result. If no one uses the track and tracing app, we get a wave that's this high, and with 80% it goes down here, and with 60% of the people using it, it comes here. Well, if we do our simulation, if no one uses it, we get up here. So this is more or less the same height. But if 60% of the people use the app, we still got here, and if 80% used it, we get here. So our waves are much bigger. So the effect of the track and tracing app seems to be much smaller. So what we're doing now is actually tracing back, and I think that's one of the big advantages of using this agent-based model, tracing back where does the difference come from. And for a large part, this comes of where do people get infected, and how many contacts do they actually assume people have? And we see that people have far more contacts than they assume in the Oxford model. And we see that a lot of people actually get infected at home. And although track and tracing app will work, you already get those people. If someone is infected, goes home in quarantine, then the rest of the homemates will also be infected, no matter what you do. So you don't need a track and tracing app to get to those people. So track and tracing apps in general are not effective, and actually slowly this gets confirmed by a lot of the practical cases. So starting from a principal agent-based approach works. You need an internal state to balance all the influences that we have. The needs model works for a limited setting. Too many aspects make it impractical to calibrate. So we see we got a lot of requests based on our results for also incorporating other things. And the more we started incorporating them, the more difficult it is to calibrate all the different needs. So we're actually, this is the last point, report to repass at this moment, and we're right away strengthen the architecture to make this more contextualized. We need actually better tools to describe all the scenarios. That's done in a quite primitive way by using text files at the moment. And we need far better tools to generate agent population. So there are things that do things on demographics, but then it's difficult to incorporate what if we have different actions available, add more actions, add different needs there. So to integrate all these different things, you need tools to actually easily give some statistics on all those different parts, indicate how they influence behavior, and then put it all together. And that's something that's still quite lacking. And we also need far better tools for presenting the results. We've done a lot of things now in Unity, but it's more or less our getting it together. There's nothing really that can readily be used by other people. Okay, that's my slideshow.
Thanks, Frank. And I think the time deficit has slightly increased due to different circumstances during this session, but we will follow the same strategy as in the previous session. So each of the presenters will pick one item of the either Google Doc or their own IDs or the chat that they want to pick up. And we start with Nick. Nick, what would you like to pick up in the live discussion here, and give either a short answer or just pose some questions?
Okay, well, the question was raised, isn't it likely that many different combinations of parameters would give the sort of pattern of infection that is in our data? And of course that's possible, but we do have more detailed data about who became infected when, and to some extent who may have infected whom, because of the differences in viral strains, than is the case in almost any epidemiological study I've seen. We also have expert virologists on the team who can help us winnow the most likely or least likely combinations, and we're considering what methods to use to search through the large combination of parameters there are. We may well use approximate Bayesian computation, which can help to identify which aspects of a model are actually making an important difference, and help to simplify models in some cases if some parameters turn out not really to be doing very much.
Thanks a lot, Nick. Alexis, anything you would like to pick up? Or
well, actually, I don't have anything to pick up because there are no questions, so it's going to be easy. No, okay. No. Actually, there is a general question, which or general suggestion maybe, which I find very, very interesting. Is the possibility to develop or to make accessible a common data set, complete data set, so that all models can be maybe compared on the same data set, and maybe also to understand the limitations and constraints of each model. So I find it a fantastic suggestion. I don't know, because for the moment it was anonymous, so I don't know who suggested it, but I would say go ahead. It's okay. I mean, I'm waiting for it, and I would be very, very interested actually in testing the ComoKit on this, but also maybe probably in providing data sets which are a little bit different from the main ones we have seen so far, coming from European or US situations. Here we have to deal, and I just wanted to say that we have to deal with a situation which actually is very safe from a sanitary point of view, but raises a lot of problems for modelers because you don't have so many cases. Okay, we don't have cases. In most cases, I mean, when there is an outbreak, we're speaking about 10 cases. So it's absolutely ridiculous compared to what you are living and what you are facing. And in terms of building models, it's complicated. Okay, so I would be very interested to test the models on our data sets and also to provide some maybe data sets. So if someone wants to open a library or whatever, to build up these kind of things, I think it will be an invaluable contribution to the community right now.
Yes, I think that was one of the items that we had in the original editorial in the JES that started off the ROFES discussion. So I'm sure we'll pick that up. And I'm also sure that this workshop will contribute to that. Frank, what would you like to pick up?
There's one question, so it's easy.
There you go.
Are the needs containers linear? As far as I remember, yes, they are. But it doesn't need to be, I would say. So there's a lot of slack there. There's a threshold value which can change. There's the speed with which they empty up that can be changed, and different actions have different effects on the filling of the containers. So all of that influences how quick need actually becomes pressing. So, yeah, even with relatively simple models in those things, you do a pretty good job.
Which ties in a little bit to what Fredrik said. Keep your model simple, but not too simple. And I think that striking that balance is one of the greatest challenges that we all face. With that, we close off the second session, and we will have again a short break, and I will play some music, and when the music stops, we have to start again. Let's go to Pietro Terna and see how things are in Italy, and he will talk about how can ABM models become part of the policymaking process in times of emergencies.
Good morning to everyone, and many thanks to the organizer for the opportunity of introducing here our work. We started creating this model with the idea of having a tool to imagine and to propose policies for interventions. We have, as always, susceptible, infected, and recovered people, but using agent-based simulation, we micro-model the places where the contagions occur, considering homes, workplaces, as factories, offices, shops, and so on, schools, hospitals, nursing homes, and so on. We also micro-model the phenomenon of the infection, considering separately the characteristics of the infecting and of the receiving agent. The model has been created with structural data of Piedmont, an Italian region, but it can be easily calibrated to other areas. It reproduces a realistic calendar of events following the decision of the government in Italy from the region and from the state. And you have it online at this address. I reported this address also in the document, in the Google Doc document. And there you can find infos about the construction of the model, a draft paper with result, and also an executable version, because being created in NetLogo, the model has also a web version. Where the novelty? The novelty to look for policies is that of creating a way to represent the sequence of the contagions. The idea is that each infected agent is a horizontal segment with the length of its infections and the starting and end point consistent with its infection, and with the colors representing the place of the infection, not the infection, a style as a dotted, dashed, solid line representing symptomatic or asymptomatic situation and also incubation period, the thickness representing the susceptibility, so the fragility of the agent. And in this way, we can discover a lot of things. Have a look to this situation. Let me start from this picture on the bottom right place, where we can see that the agent are represented by segments. As an example, this agent in cyan color has been infected at home, and the infection is transmitted, follow my mouse, to another agent, a worker in a workplace, and so on. These are asymptomatic agents. But the story here starts from this corner, where we see a sequence of infection mainly concentrated in a brown area, so for us, workplaces. And there we have a lot of fragile agent. So agent with relevant age, but most of all having previous diseases making them very fragile. The first idea is to stop the participation to the work to fragile people, putting them at home with a sick pay, and the effect in the same conditions is the first part of this second picture, that top right, where you can see that the effect of workplaces is disappearing. The cyan color is related to home contagions, but in this case we have a bridge. Enlarging the representation, we see that the second wave of this in this world is generated by a single agent infected at home, infecting in turn another agent in the workplace. So the necessity is that of stopping all fragile people, and we do that here, and the effect is quite evident. We have, in the same condition, a short run of the simulation, and with a limited number of infected of any kind, symptomatic, asymptomatic, and diseased agent. But this is only a flash coming from a suggestion. We need something more systematic. So the decision is that of running batches of simulation, mainly over 1,000 runs, so repeating 1,000 times the running of the model with different random seeds, but always with the same rules. As an example, rules about the containment of the contagions, non-pharmaceutical rules, a regular one applied as in Italy. And how to represent the result emerging from these batches. But first of all, with the usual statistical indicator, but we adopted also, with some interest, the technique of the heat maps. And here you have two completely different cases. In the heat map, we have on the x-axis the duration of the epidemic. Each datum is an epidemic, a run of the simulation model. And on the y-axis, we have the total number of infected people. On the left, we have the heaven of negationists. Any kind, it is not existing any rule of control, of containment. Anyone is free to do what she wants. And but a few cases of epidemic with short duration and very few cases of contagion, we have a terrifying cloud with a duration of more than 1 year, or until 1 year and a half, and from 2 million to 3 million of infected people in a region with 4 million of citizens, so 4 and 350,000 people. So a effect quite dangerous, terrible. Introducing the containment rules adopted in Italy, the effect is this one. The concentration of the effects in the bottom left corner, so short duration and a limited number of contagions. And just as an example, if I enlarge, I can show you that the actual Piedmont has been here because we had the duration of this length and the limited number of infection here represented, also accounting for asymptomatic agents. From this structure that I hope can be applied also to other models, we can present several policy interventions. First of all, no control, the disaster. Second level, the use of the Italian containment rules with a very large difference. Also opening school in September, as we are doing now. But if we introduce the policy of stopping fragile workers with sick pay, sure, relevant sick pay, satisfactory sick pay, we make another step of the control of the pandemic, and we can improve it, stopping any kind of fragile people, as me, and isolating nursing home, hospital, and in this case, school is closed in September. Now, the step very interesting is that in this condition, the counterfactual decision of opening all the economic activities, factories, offices, shops, and so on, sure, increases the number of infected, the mean number of infected persons, but not dramatically. And putting there a cost-benefit analysis is very interesting. And also opening the school has no effect. There is a bit of benefit here and here, mainly due to the fact that we keep a part of the young people constrained in a safe place, school, in the large part of the day, not leaving them go around. Finally, a short reply to the questions of the organizer. This kind of methodology is not for forecasting, I underline that, is for making comparative analysis. Being our model, now it is our model, not the methodology, highly parametric, we can easily adapt it to other situations, and it will be more parametric in a second version that we are starting to build using Python in a shell built by myself. This is scientific advertising because the shell is completely free, and it is created starting from the old structure of the swarm model from Santa Fe. That's all. Many thanks for your attention.
Thanks a lot, Pietro. And for the final presentation of this session, we go to Andreas, who will talk about the Artificial University.
Hello everyone, how are you doing? So I try to share. And you should see my screen?
We do indeed.
Wonderful. So I'm sharing the fate of Jason as it's in Virginia approximately 1 hour to breakfast. The good news is that I'm presenting the COVID Healthcare Coalition, and they provided me with a coffee mug, so that's why I use this affiliation and providing you information about the Artificial University in the section on policymaking. I co-worked on this with a lot of people, but I definitely want to mention Professor Wesley Wildman from the Center for Mind and Culture, who is on the call also and who can help me with answering questions if there are any. My actual affiliation is the MIDA Corporation, and the MIDA Corporation is a federally funded research and development center based organization, which means that we are doing research for the federal government on all levels. And when the pandemic did hit, MIDA, together with the Mayo Clinic, did set up the COVID-19 Healthcare Coalition as a private sector, non-commercial interest organization coalition to save lives, as many lives as possible. And we had lots of different coalition groups, working groups, and I was mainly working in the group for analytics as the working group chair for modeling and simulation. And when you look at what we found out when we wrote all these different partners together, to give you an idea, the Healthcare Coalition had approximately 900 members, including members from Microsoft, Google, Amazon, providing a lot of very good services to collect data, to share data, to evaluate data. We had partners from the national labs, we had partners from the big universities, and we tried to find out what kind of modeling and simulation do we need in order to support such a problem as the pandemic. And you all remember that we started with the SEER models in the beginning and very often totally overshot the target, had way too high predictions, and a lot of people started to send hate mails like Jason told us earlier, because they felt betrayed, because they wanted to have this crystal ball of a modeling and simulation to tell them exactly what to do and how to control the world. We as scientists know that we often feel a little bit like young Malcolm in Jurassic Park, when people try to control a chaotic, complex system where just a very minimal change can lead to a completely different outcome, and we have the illusion to be able to have everything under control with a nice mathematical model. We can't. Our models are to think with, and that is also one of the main lessons that we are trying to educate our policymakers in. So what we see with COVID-19 is that it's a multi-value, multi-criteria decision space. Multi-criteria, lots of things have to be taken into consideration. Multi-value, lots of outcomes have to be taken into consideration. What we have seen in the beginning was that we focused nearly exclusively to save lives and to make sure that a few people as possible were infected. As a result, lots of the economy broke down, lots of the local businesses broke down, starting to see social unrest in families. We see a significant increase in suicides, opioid overdoses, because people are losing their social connections. So we cannot just optimize something, we have to provide this multi-value, multi-attribute idea. And we want to take into account not only the quantitative data, we also want to have quantitative data and qualitative data equally being able to be taken into consideration. And one of the big challenges that we very often see with our decision makers is that this idea of highly time dependence is not deeply ingrained. They want to see an immediate reaction when they make a control. If you look into COVID, it may take 14 days, it may take 2 weeks, maybe 3 weeks, 4 weeks, or even more before the policy actually takes effect. And with simulation, we can show them. And we decided, and by the way, thank you to Alexis for ComoKit, because ComoKit was one of the models we looked at early on to see what others are doing in this direction, that an artificial society is a very, very good way to go to. And the reason is that it's able to be spatially explicit for the regions. You're able to represent the demographics for regions. You can represent social networks. You can represent mobility. And so you can bring a lot of very important factors into this model to think with it. You have to be careful. If you build a model, you very easily fall into the trap that you model what you believe in, and then you prove the model to prove that what you believe in is right. And I have witnessed discussions with experts where the data scientist says, oh, the data does not support this idea, and then the decision maker says, then we have to find better data. So that's something we can unfortunately not address with our models, but at least we can show that maybe the data is not so completely off. Then the artificial society can be embedded into the situated environment. And everything we know from the outside is going to influence us accordingly. The good news with the artificial society is that every expert from all the different domains, and with 900 members, we have lots of different disciplines coming together, could contribute his or her facet of the problem. And by doing so, we could run them all at the same time with this artificial society to show where is which development and what does a decision actually lead to. Very much like the presentations that we heard before. Two ideas that I would like to mention here is that we want to support exploratory analysis because we do not believe that just parameter analysis is sufficient. I think that we even have to address different models and different model aspects. And that's why I made a recommendation. Maybe we want to compare all the models to create this uncertainty cone and better understand what the different viewpoints are, because not any model is going to comprise all these real things that are of interest. And the reason for this is that our problem is understood as a problem of deep uncertainty. Deep uncertainty means that even the experts do not agree on what is the right model and what is the right approach. So in a nutshell, this model is great to think with and to present what are the different aspects. With our group, we were not able to, as we are a pro bono organization, the Coalition of the Willings, to build a supermodel of the United States or do something which is comparable with a lot of the CDC activities, or even with the big artificial society models as they were used by the Biocomplexity Institute of the University of Virginia, the Harko National Lab, or the Georgia Tech University. They are using artificial models that are requiring high performance computing clusters to run all this because they have millions of agents that all are interacting accordingly. We wanted to have something which is applicable, and we realized that if we want to do so, we have to bring the human factors way more into the ways that we are currently working with these models. And we just had a presentation where we saw how important human factors are, that the moment you bring them in, suddenly your wonderful, nice curves that you can produce by the simple SER models are becoming a little bit shaky because people do not always behave like a mindless agent, but they have all these fears, they have all these anxieties, they have all these desires, and so on. I do not want to go into the details, but this is a model where we started to look into what are the human factors that are important. What I want to focus on is how do we apply this for policymaking in universities, and that is the artificial university. What we did is we took these ideas of the socially capable agent in a constrained environment of a university, looking into the building constraints, the schedule constraints, the connection constraints, the event constraints, and then gave policymakers for the university the option to come up with different policies. So that meant that we looked at how many parties are there. Are parties allowed? Do we allow tailgating? Do we allow sport events? If you're in the United States and you are in Texas and you tell a university to close down the football program, you can easily say, no, we are going to close the churches in Rome. So there is a lot of these social cultural aspects that are influencing the decision making. And in particular, students that are at the universities do not always like to comply to the same degrees that someone who is a little bit more mature, in particular as they are under 25, so are still all invincible and all immortal. And so a lot of this has to be taken into consideration and can be taken into consideration with the artificial university elements. We encoded the different elements that we had there, and this information was utilized to run a couple of demonstrations. I just give you two, there are a couple of more. I realized, as we heard from Pietro, how important it is to have a good visualization. We also realized that decision makers like to make decisions as long as they are not more than three. So to provide them with a model with all these different parameter options that you can adjust here a little bit and there a little bit was often perceived to be counterproductive. So it was more, what are the main big decisions that I want to make and what are the trend analysis that the model can give us. What you see on the left-hand side was a run where we looked into the different possibilities of policies like enforcing physical distancing, monitoring, contact tracing, testing for the student and faculty staff for the virus. And what we did on the left-hand side, we did analysis, what is the single best factor that is contributing to make sure that the number of people never infected is as big as possible. And physical distancing was identified as the most important one. And if you add contact tracing, you can increase it. If you add contact tracing and do testing, you can increase it. But the most important one is physical distancing. So we also looked into distancing at the compliance of students, because it's a human factor. And what you see on the right-hand side is the number of people never infected in comparison with how compliant are students with this rule to follow the physical distance rule. And what you see here is that up to a point, to approximately 60% people in this compliance range, you are still in a relatively good shape, but in the moment you are passing this tipping point, things go south. So what does this mean? If physical distance is really our main things that we are interested in, we should encourage everything that makes physical distancing easier and training students and faculty to really focus on the compliance as a good practice. And this can now be played off with all the other elements, including the questions of TNT that we just heard before. It's definitely not the silver bullet, but it's definitely something in our application we found is very interesting. When we came up with this, what we mainly wanted to do is we wanted to provide this as a source and as a tool for the communities to give back. Within the United States, we have a lot of traditionally Black universities that are not always as wealthy and well-funded as the universities that are in the Ivy League. So they are very unlikely to be able to do a study. Go to UVA or Virginia Tech or to one of the other big schools, they have faculty and money to run their own simulation systems and run their own recommendations and come up with their own policies. We wanted to provide, in particular, those colleges that are serving normally underserved communities the opportunity to just download the code, adapt it to their needs, and so on, and made it openly available. The link is in the chat documentation as well as here. What I would like to focus on is that this is a real healthcare coalition product with contributions from several members. Thanks for the Center of Mind and Culture that they took the lead within the Human Simulation Group to host the source code and to make sure that feedback comes back. In this group, I definitely ask for your feedback because you are the experts that can help us to make this code better, so that we hopefully are going to help many students to cope with COVID and get a good education without having to drop all the fun. So that is what I wanted to talk about. As always, that is mainly the opinions of the participants and presenters of this. This is not an official government presentation, that's just our recommendation. So with this, I have to stop sharing.
Thanks a lot, Andreas. While you stop sharing, we go back to Jason and ask Jason to pick up a question or a comment that he would like to address.
Oh, okay. I think the interesting thing, one of the questions about, well, I'll pick the hate mail one. One of the, I mean, it's certainly, I mean, I know that we're not alone, but it certainly means that we're having impact, I suppose. You know, it means that we're doing something, we're having some policy impact, and then, you know, rightly or wrongly, if we're getting blamed for that, and I would say it's wrongly, because all we do is advise what our estimates are based on what it is that we do, you know, but something is happening. And there's a saying by a a politician, a famous politician in Australia, who said, "You'll never be anyone until you get a good bunch of enemies." And I think I'm having to rely on that at some point, or these days, because the right people, the people who are wanting. Who, in my personal opinion, would want the wrong things for community health and for society, don't like what it is that we're saying. So, or don't like the risk profiles, at least, that we're producing. We're not saying the government has to accept those risks or should do anything. We're just sort of saying that this is what it is. So I think that's it. I suppose very briefly, the second one is we worked with some people within government who were absolutely excellent data visualization masters, and it wasn't until we did that I really understood the power of them being able to very quickly produce and explain our models better than I ever could. So that's been absolutely essential for getting those messages across to policymakers. A bit like Frank, we heard before, I've been playing around with Unity and Godot and some of these things, thinking that the interface is if we can make the interface realistic, that's good. I've given up on all of those ideas now, and I'm simply going back to the data visualization in the simplest model representation that I can. The interface for me now is now secondary.
Thanks a lot for that, Jason. Then we go to Pietro. Pietro, is there anything you'd like to pick up from this session or previous sessions or from the discussion in the Google Doc?
No direct questions, but I am interested to a general question to the session.
Mm-hmm.
And how we verify if our idea coming from our models, maybe vastly model-oriented to political proposal, are spreading in the society. This is a very interesting question. We had a lot of difficulties interacting with professional politicians, but we easily interacted with journalists, teachers for the school problems, and very, very interesting occupational physicians who are very interested how to now control the workplaces.
Right.
And with a bit of satisfaction, I see that now the Italian debate is taking in account indirectly, with the mysterious spreading, the idea that fragile people has to be kept in a safe place. And this is interesting. It's not a success, but I hope to have contributed. Stop.
Great, thanks a lot. Andreas, anything you'd like to add to the presentation that just ended that is connected to what we've been discussing so far, either in Google Doc or in the presentations?
Yeah, I had one remark regarding if a model is just a thinking tool, then how do you know if the thinking is encouraging to the right things that happen in real societies? And just a thinking tool may be a little bit of an overstatement. Obviously, the thinking tool must be very highly correlated to reality as highly as possible. What I only want to discourage from is to see the modeling and simulation application, even if it is as sophisticated as possible as a crystal ball. It never is. It cannot be. That's what we know from complexity theory. And that is something which is, in particular in decision making and decision support, too rarely communicated, because people say, here is the solution. No, it is a solution that is highly likely to lead to a desired effect. And what are the alternatives? Alternatives, sharing of generic lists, or doing a private consultants, or looking into some alternative models. It's going to be a tool. And that is what we have to emphasize, that people understand. We are helping them to govern. We are not helping them to control. We are helping them to make decisions. We are not making a decision.
I think those are wise words, and with that, I suggest we round off session number 3, take a little break, and get some energy for the 4th and final session. So welcome back everyone for the fourth and final session of the workshop on simulation in the times of COVID-19. And we start with the first presentation in the final session called Crisis and ABM. Juliette Rocher will present information and modeling during crisis. There you go, Juliette.
Hello, I have a problem, of course, to reach the, that's it. Hello, thank you for this invitation to speak. So I'm going to present something which is a bit more general than just my model, but actually it's a lot about one idea I had because we had a lot of lack of information during this period. And so I wanted to present the trick I found so that to reduce the quantity of information I had so that to be able to work on the issue of what could be done with this crisis anyway. So the reason why I did that, although I'm not working on viruses, usually I'm just working on diffusion of opinion, innovation and things like that. It's just that there was this huge stress in the community when we suddenly realized that maybe the blind lockdown in Europe, which was in many countries like blind, like really everything was stopped. And we will certainly see the problems coming in economic life very soon. And it was justified, apparently, partly by the Ferguson model, which was, when you had to go through it, not so convincing for prediction in such a context. There was something very weird I found when criticizing this model, and which has been stressed in these sessions in the morning. It's like you really missed a lot of interaction that were like the wedding, the church, the pub. It was very much on everyday interactions, whereas we have known very early in this epidemic that there were some very big events that had spread the disease, especially in France. Most of the big crises was due to some very precise events where 2,000 people were in contact, and then it started, whether we were in contact with one person or a few people, and then it started. And also we had a very high mortality rate, 3%, whereas we had in February the data on Diamond Princess. And if you look at the data, it's closer to 3, 4, 1,000 deaths. So it was interesting to see that there could be a very drastic situation taking place, whereas it was not so difficult to see that there were some problems in the model. So that did stress the community. And I thought, okay, so let's think about what I could do as well. And diversity was one of the answers. And I can see that it did work because now we have many proposals from different point of view, different ways of representing also the epidemic. So that's really interesting. And the way you look at the models. So that's really fascinating. And also I was thinking, okay, we might have some meta results. So if everybody does an ad hoc model for each question is asking, then at some point we can find commonalities or not, and start discussing maybe for the future how to react in this type of situation. Especially, it's quite rare that we have a problem that addresses agent-based models. But I never wonder about the legitimacy, as was asked by Nigel, because no one was asking me anything. So anyway, I could produce what I do as usual. I'm not part of experts group. So I would say I have no problem in doing my usual work. I think there is, after working a bit, there is not so much difference with other diffusion models. I mean, the main problems and the main issues in the representations are the same. And also I decided to take a pedagogical approach because I explained the critiques I had for Ferguson in French in a journal, and I got some very nice feedback. So I just wrote a book actually in French with 2 critiques of model and 3 proposals, and explanation about what could be done with those models potentially. So that I redirected the energy to trying to explain to everyone why we had been locked down because of a model and how we can interpret them. So it was difficult because we if you have to consider a SEER model, you have many moments where you have probabilities. And you have the probabilities of transmission, you have the probability of changing states for each transition between states. So you have the asymptomatic or first days, that then you can be a bit ill, you can be hospitalized, you can go to intensive care, you can recover, and you can be dead. But I did not consider death because there are many measurement problems with death. So I find it difficult to discuss about that in this context. And of course, we knew that asymptomatic was very important. You had to represent that because it was key in the speed in the diffusion. And also, it was one of the major problems in the whole paranoid speeches and paranoid view and many public decisions that were very hard because anyway, you could never know because there were so many asymptomatic bad people. It was like, they are among us, blah, blah, blah. So that was central because be it for a psychological reason or technical reason, they were very important. And also there was something massive, which was the population at risk because eventually people who died were old, more than 65 for more than, I don't remember, it's 80% is more than 65, I think, like that. Well, a lot of male and a lot with comorbidity. So it was, and also the definition kind of evolved because at the beginning it was not so clear that people with diabetes were that touched and also people who were very fat, etc. And it appeared, I would say in April, to be very clear. So everything was a bit moving. So we needed to have this type of definitions. You know, you have asymptomatic, you have a population at risk. But the description of how you do that was not so easy for me. And I could not know how to make this percentage because the values, I had to do retro engineering statistics on data we didn't have in quantity and in a sufficient quantity. And also, I don't know how to do that. So I thought, okay, let's do as usual. You will do the category representation. And so the category was just to fit stories of disease. Say, okay, when you get the disease, I give you as an agent a story, and now your story will be that. So when an agent is touched, I know if he's going to be dead in 3 weeks as a modeler. And it really simplified the point of view, although it forces to other type of simplification, of course. And also there was a second point, which I really liked, which was this great hypothesis of the hydroxychloroquine and macrolide antibiotic as an early cure. So at the end of this, since I can imagine that some people say, this is not good science, I'm just giving the two quite recent date links, which are at the bottom of the slide. I sent my slides also. And what it says, you can go to the link and it says that nothing is clear about that. Does it have an effect? What is the size of the effect? Whatever. It's not really settled. So for me, it's still an hypothesis I'm allowed to put in a model up until it's refuted. I just can keep it. And second thing, I think that there was something about caring, like that was a bit touching in this proposal, which are you detect, you reassure people, and you promise that you will take care of them, etc. And eventually, it was so cool for ABM because you have an individual reduction of viral load, which means that for a shorter time, the people are going to be contagious. So they're going to be less contagious in time. And then you have to know what are the conditions under which it's going to have an effect at the higher level. So for me, it wasn't a process like a la shilling, like a small thing that can, and in shilling, you know that if you want 30% a la shilling, like in NetLogo, if you want 30% of people being similar to you, you get having 80% of people being similar to you. And and also my idea of having this story of life of the disease was very interesting because here it was very easy to write because once you get the cure, you just change the story you're going to live with. And you just say, okay, now I'm going to take a story where I don't go to intensive care, for example. So the two hypotheses I've taken is that you are ill for less time, so you're less contagious in the process. And you reduce the number of intensive care. So not here, I wrote death, but it's intensive care. As again, my disease trajectory story was really made to have no complex statistic, but be able to write a model anyway. And then the idea was to compare between different public policy, like everybody, and to have some different, show that you can have some different indicators. So it's very toy model to show how you can work on that. And so we have the indicator, which is the number of people in intensive care, which is the major problem in our hospital system, and the number of people working at the same time, or carry on working with no problem. And of course, as many people ask here, or wonder about here, my question is also how much policies are applicable. Because of course you can design policies in models, but you have a large uncertainty. That's what I call uncertainty is a model. So here I have tested the lockdown, simple, with 2 lengths. Here I just give you about 2 lengths of lockdown, and the protocol with hydroxychloroquine. And both have problems because the lockdown is not respected, especially we are in Marseille. I'm in Marseille, so in Marseille, it's not respected in many, many neighborhoods. So you say, okay, so what is the tolerance for this respect? And then for the protocol, you have a huge probability of false negative in the PCR test, which is 30 to 40%. So it means that even if you want to do a politics where you can reduce to people individually, but you can miss many people. So where does it go? And does it give something at the end? Or no. And also, hello, Alexis, this could be integrated, this type of assumption can be integrated in other type of meta model where you have a better representation of networks than the one I did, etc. So I guess that it's not contradictory with many things. So I do a model with a lockdown, you stay home, you reduce your contact. So normal life is that you have 2 people at home with you and 40 relations outside. So it's extremely coarse. And I know that some other people have really worked on making nice models of real life relationship and regularity, either on regularity or on unregular relations. But this is very silly with homogeneity. And in the model, well, we have a test for 1% of the agents without sign, and if they are detected, they are put at home. So detected as being ill, as being carrier of the disease, they are put at home and they get cured, so they get the effect. And anyone who is ill is going home and is tested. And if detected, because you have this probability of not being detected, then you stay home as well, and you get cured when detected. And actually, so you have a transformation of your life, of what can be. So you start out asymptomatic. If you are asymptomatic and you get cured, then you change your path in the asymptomatic life, let's say asymptomatic, and you are asymptomatic less long, and you transmit less. And all this is translated like that. Extremely ad hoc translation. I mean, I could do it because it's possible. You could tell stories, so you could invent individual stories from what was described, so from qualitative description of what was happening. But it means a huge simplification because we, of course, not every asymptomatic was for 15 days. Simple disease could last for 3 months and not just 14, etc., etc. So this is extremely sketchy, but it doesn't have too many things to vary, too many parameters, which can be nice as well. So you can really play with it. And what is interesting, because we did 3 models, so every time we model in a different way. But what I find interesting is that it's very easy whenever you do an infection of that sort, where you can be cured and not be infective anymore, you make the curve very easily. That's and I guess you can fit curves very easily. So that's a bit annoying because deciding which model is better is not going to be very easy for us. And okay, the normal curve is the blue one, and if you apply a perfect curing system, then you get to something very low. What I find interesting here is that when you do the lockdown, you automatically have very large second wave. And this was true on the other models we did. And that's a bit of an annoyance for me, because in nowhere we had a wave which is higher right after the end of the lockdown. So that's a bit of annoying for for my models. And of course, if I add two policies, which was my original idea, then if you do the lockdown and you do you give a cure, which is the yellow one, cure and people who don't work when they're ill, you get extraordinarily nice results. And that's where maybe mixing of practices could have been nice in our recent past. Of course, what is always difficult is that you have different heights and different lengths, so you never know how to consider what is important. So of course, the highest peak is important, and the length and the total number of people who have been touched can be kind of important. And so I wouldn't say my results are extraordinarily interesting or fitting or whatever. They help me to think further, let's say, and I will try to do that better maybe for a paper. But I could get some interesting results, like during the lockdown, it's better to have 30 people outside working and meeting others than to have 20. It's better if everybody better at the end of the epidemics, not necessarily during the peak. And even the peak is not higher than when you have 20% only of the people outside. So you can have counterintuitive effect. I mean, and that's what I'm looking for when I'm doing models. It's like when there is something I don't really understand, but then I will have to explore better to understand why it's better to be more numerous outside and why it slows down the whole epidemics. Okay, that's when people are not cured. That's just the lockdown. And of course you can get, as I said, which is again a very toy model, but you can get the number of people working at some time, etc. So you can really discuss multi-criteria politics. You could always calculate how much it costs. And I guess in some ways, if we had put all efforts to work collectively, let's say, which didn't work that well. Okay, so the concluded note, that I think the trajectories are a good idea. Because they were very, very easy to write. And they are very intuitive also to discuss with diverse people. Well, when represented homogeneously, you get a very low transmission rate, which makes me think that this hypothesis about the super spreading event is central, because this is always true. If you want a R0, which is between 2 and 3, you need to have a very, very low chance to give the disease at each encounter, at each contact. And okay, I think that it means that we are not talking about something which is average, but this can be discussed, average or homogeneous all the time. And the mixing of policy has really to be thought, but as you could see, maybe sometimes you have to find new ways of modeling because it's not going to be obvious to mix the policies. Expressivity is not always easy. Interesting and unexpected results is my counterintuitive better to have 30% outside than 20, which I will try to understand better. And okay, I already said the other things. For the cure, of course, that's the quality of testing, which is very important. Well, I didn't say, but it was working very well. If you have a highly false negative rate, then it doesn't work. I mean, the higher the false negative rate, the less the impact. So this is very, very logically linear, not interesting, per se. Or at least I did not produce something interesting. And we get more or less the same result, even if we are very much less optimistic, because this coding was optimistic for the cure impact. And if you are much less optimistic, you get similar results with slightly different amplitude, and for example, the impact of testing is less. So I don't know, this can also be tested further. And that's all I wanted to say. But this is a toy model, but I think it helps thinking as well in a time of production of reflection. Okay.
Thanks, Juliette. And now we rush on to Laurent. Laurent, are you ready?
Yes.
Go ahead.
Can you see my screen?
Yes, we see the screen. We see the edit view right now of these slides. And now we see the slideshow.
Okay. Excellent. Excellent. Thank you, Harko. Thank you, everyone, for hanging out till the end of the session. As I've listened to the presentation so far, I think that what we're doing here in the Emoticon project complements several of the other projects. We're obviously interested in policy, responding to the Research Council of Norway's request for research on this topic. And also, we pay really no attention specifically to the disease spreading here. Our focus is completely on the human and social dynamics, which of course can feed back and make the disease worse. Also, the first word on our subtitle kind of gives away my opinion on the next session, but won't spend time on that here. The Emoticon project is funded by the Research Council of Norway. We just got started last month, so I only have a few initial results to share with you. The overarching goal is to assist in the development of strategies to combat the spread of misinformation. That includes conspiracy theories related to COVID-19, stigma, especially related to certain ethnic groups, but also age, and fear, anxiety, whether related to isolation or other social threats, whatever that might be in the population. And the goal is specifically to learn what we can from COVID-19 so that we can be ready for either additional waves or for other pandemics that come down later. The outputs of the project will hopefully be user-friendly artificial intelligence tools that will help municipalities. This is our reference group, municipalities in Norway. Analyze and forecast the societal effects of their public health responses and social countermeasures to pandemics. And secondly, experiment with alternative intervention strategies for flattening the curve of psychologically and politically debilitating social contagion. So our analogy here is just as we need to flatten the curve for the disease itself, we need to flatten the curve of psychologically and politically sharing these kinds of misinformation or stigma or fear. The goal is to develop an artificial society that comes as close as possible to at least abstractly simulating the Norwegian population so that it will be useful to the policymakers. We're going to be using social media analysis and survey data to inform the model for validation purposes, aiming to get at the cultural dimensions of the societal reaction to the disease, to reveal mechanisms and forecast patterns in which individuals and communities understand and react to COVID-19. If we pull it off, we'll have both quantitative and qualitative data in dialogue with our reference group that will then be shaped by what specific policy levers they're telling us that they have or don't have in order to try to halt or at least slow down the spread of misinformation, stigma, and fear. Our research teams have already published computational models that simulate the effect of a disease and social contagion threats. They also include natural hazards threats as well as predation threats, because these are those that evolutionary biology suggests are the most powerful for humans. That was published in a journal most of you are familiar with. The goal then is to take this model and to adapt it to simulate the emotional and behavioral effects of disease contagion threats specifically under a wide variety of parameters that are, again, our reference group will help us with. We're trying to design the model itself to enable stakeholders to figure out what those thresholds are that can lead to tipping points where, just like with the disease, suddenly there's an outbreak in the same way, what causes an outbreak, as it were, of misinformation or fear or stigma. Here's the big picture of the project. Work package 1 organizes it. Work package 2 is the social media analytics. 3, the survey itself. So far in the first month and a half, we've just begun the social media analysis. The survey, which is in Norwegian, is just being finalized, will be done here in Gallup, using Gallup in Norway, using their panel data. And then that will inform the model itself, which along with our stakeholders will be developing in a way that ideally gives us an artificial society for experimentation. So briefly, social media analysis. The first phase, we're downloading and analyzing tweets, mostly Twitter, but also Reddit and some other social media, trying to detect sentiment, even some personality analysis, networks, how and when and why are they spreading, and in which parts of Norway by which kinds of people. So far we've got a couple of interesting findings. Those of you who are familiar with moral foundations theory, these are based on biocultural analysis of human evolution, that there are 5 basic moral foundations that drive people. Mostly when you do social media analysis, you get a kind of general morality. Here, this light blue is by far the largest. But in this case, we're getting purity. Purity as a driver for moral indignation is by far the largest. So that is a kind of validation of what we're doing. We're talking about a disease, and if we're picking up, detecting purity anxiety, that suggests we're doing something right. So secondly, here's just a quick presentation of some of the main hashtags in Norway. If you look there along the bottom, you'll see Sweden comes up a lot, as you might expect. Our neighbors to the east have been famous or infamous globally for the way they've responded. Norway shut down the border months ago. It won't let anyone travel to or from Sweden. Why Batman appears? We have not yet done the analysis on that one. The survey is, as I mentioned, just in the process of being completed. We'll be using panel data. We'll try to get at the attitudes and behaviors of Norwegians, getting at conspiracy theories again, misinformation, epistemic vice. As much as we can, we're using already validated survey questions to get at these issues, as well as fear and anxiety and stigma. Both of those will inform the computer model. The final phase, we've already starting to structure and develop initial agent variables and think about the social networks we need and parameters. But at this point, we're still in dialogue with our municipality, healthcare leaders and the other stakeholders as we're starting to design that model. The goal is to have the survey done and out by the end of this month. We're doing it once this month, and we'll try to do it again in February so we can get longitudinal responses and use that, if possible, to calibrate the model. So that's it.
Thanks a lot, Riron. As the general host of the Social Simulation Week has another session starting at 14, and this workshop will be shut down in 11 minutes. We will pick up 1 question each as previously, and that's about it. The Google Doc will stay open. But we first go to Juliet. Juliet, is there anything you want to pick up from the discussion in the Google Doc? Maybe not the one you're having very intensive with Bruce currently.
It's better with the microphone. The discussion with Bruce, I didn't want to have because that's why I say, okay, there is still a discussion. I think what is interesting is why it pushed me to find some other way to model the question and to be in, to find a way to make it possible to make some of the parameters evolve. Nick is right. It's not really 2%. I'm sorry. It's less than 2%. I don't know why I did this calculation yesterday when doing my slides. this is silly. For the justify story, that was the interesting element I heard this morning, because I think this is related in the way I conceived the way I modeled. It's like, I think it's nicer effectively to take the qualitative stories and to try to implement them and to compare situations that can be described a bit more seriously like that.
Thank you, Juliette. I think we would like to move on to Laurent now, so and then we can wrap up the session before the plug is pulled on us. Laurent.
Yes, thank you, Harko. I just have one question, it looks like, from Alexander. The only culture we're including here is Norway, but we're pulling down data from social media all over the world globally, hundreds of millions of tweets. So eventually, if we find partners, we hope to adopt it and apply it to other contexts as well.
Thanks a lot, Rion. And with that, like I said, the Google Doc will stay open so we can continue discussing there. There will also be a special issue of CMOD on COVID-related simulations. The call for papers will be out soon. And I thank everyone for being very, I would say, active participant or presenter. And even at this late moment, we still have about 60 people online. And at the top, we were almost 100. So I think things are pretty good. So we can silently applaud ourselves and everyone else who was in the session. And we will wrap up with some music just to make sure that we have a smooth transition until what may be a late lunch, at least for me. Thanks a lot, everyone.